So those of you that were at last year's meeting in Philadelphia know the ground rules for this rapid fire abstract session. Me and Deepak are going to run a very, very tight ship. Everyone has 5 minutes to present their abstracts. And if you don't present within 5 minutes, there's an eject button we're going to hit, and you're going to get popped into the Charles right next door over there. So please try to stay within time. All jokes aside, this is going to be a terrific session. We're going to go ahead and kick things off with Dr. Prathyusha Konda from the Dana-Farber, who's going to discuss single-cell sequencing for translocation renal cell carcinoma. Welcome.
Good afternoon, everyone. Firstly, I want to thank the KCRS Organizing Committee and the Abstract Selection Committee for giving me this opportunity to speak here today. So I'm Prathyusha. I'm a postdoc in Dr. Srini Vishwanathan's lab at Dana-Farber. Today, I'm going to talk about translocation renal cell carcinoma and how we are trying to understand the tumor-intrinsic and tumor-extrinsic factors within this subtype. So translocation renal cell carcinoma is a rare subtype of kidney cancer and accounts for about 1 to 5% of RCCs in adults and about 50% of RCCs in children. Molecularly, this subtype is characterized by a genetic fusion involving MIT-TFE family genes, along with any of the 20 partner genes that have been identified so far. And previous work from our lab showed that in this subtype, really the fusion is the only driving oncogenic factor, and genetically it has a very quiet landscape as compared to CCRCC. So right now, we don't have any molecularly tailored treatments for translocation RCC. So this project is focused on understanding both the tumor-intrinsic as well as tumor-extrinsic factors with the idea of identifying targets for clinical use. And this is a collaboration with Dr. Tony Chori, who has been integral to kickstart this project. So we recently collected a cohort of translocation renal cell carcinomas at Dana-Farber. We have a total of 11 samples constituting of 10 tumor samples and 1 adjacent normal. And within this cohort, we also have 4 samples coming from 1 patient, which includes a primary as well as 3 metastatic sites from that patient. The cell types that we have identified include the majority of cells belonging to tumor cells, as well as myeloid cells, lymphocytes, endothelial cells, and fibroblasts. In total, we have our cohort has about 71,000 cells, and about 43,000 of them belong to the tumor cells. Within the tumor compartment, we noticed that there is quite a bit of transcriptional variability in this subtype, which is interesting given that genetically this has a very quiet and homogeneous landscape. So we noticed that some clusters or some tumor populations are specific to a patient. For instance, this cluster 1, which belongs to only 1 patient, whereas the remaining patient seems to have a little more similar transcriptional profiles. And within these subclusters, we also noticed that different clusters are regulated by different transcription factors. As an example, I'm demonstrating here a subcluster of tumor cells, which has high RUNX2 activity, and it also has a high EMT associated modules. So we hypothesized that maybe this fusion itself is pairing with other transcription factors and driving different transcriptional states within TRCC. However, for that to happen, the tumor also needs to arise in the right cell of origin. And right now, we don't have a clear understanding of the cell of origin for translocation renal cell carcinoma. So we looked at this analysis. And first, we confirmed our analysis by looking at CCRCC. By looking at CCRCC, which is highlighted in blue here, and as well as chromophobe RCC, which is highlighted in yellow. And we confirmed that those 2 subtypes belong to proximal tubule and intercalated cells respectively, which has been previously confirmed. And within TRCC, we noticed that there is some heterogeneity. About 60% of samples from our in-house cohort, as well as the public cohorts that we analyzed, seem to be arising from proximal tubules, whereas the remaining about 40% of samples seem to be coming from the distal nephron, which is quite interesting. Next, we are also interested in the tumor microenvironment, and as Dr. David Brown mentioned this morning, it is quite heterogeneous, and it's very different in RCCs compared to other cancer types. And within RCCs too, TRCC seems to have a different tumor microenvironment as compared to CCRCC, for instance. There is a very small proportion of T cell infiltration in TRCCs as compared to CCRCCs. However, interestingly, within that small proportion of T cells that are infiltrating the tumor, when we analyze those cells coming from samples which had prior ICI treatment versus the samples without any treatment, we notice that there is enhanced progenitor exhausted and terminal exhausted phenotypes, indicating that there was an initial activation of T cells in response to the ICI. This might indicate why some TRCC patients seem to respond in the clinics as well. So with that, I would like to thank my supervisor, Dr. Srinivas Vishwanathan, for his continued support, and everyone on the Vishwanathan lab, as well as our collaborators, mainly Dr. Tony Cherry, who was instrumental in this work. And I also want to thank the funding agencies, particularly DOD, KCRP, for funding my postdoctoral fellowship as well as this project. Thank you so much.
Thank you, Prathyusha. Next, I'd like to invite Dr. Labaki to discuss characterization of cellular origin and oncogenic mechanisms of chromophobe renal cell carcinoma and renal oncocytic neoplasms.
Thank you. Thank you very much. Hello, everyone. Thank you for the opportunity to present at KCRS. I will be talking about our work regarding the characterization of the cellular origin and the oncogenic mechanisms in chromophobe RCC and renal oncocytic neoplasms. So when thinking about the cell of origin of chromophobe RCC and renal oncocytic tumors, chromophobe RCC is thought to originate from the integrated cells of the collecting duct, based on previous works using bulk RNA-seq data. For renal oncocytoma and low-grade oncocytic tumors, the cell of origin remains so far unknown. Additionally, there is a limited knowledge regarding the mechanisms of tumorigenesis in chromophobe RCC. And so the aims of our work were to identify the exact cellular origin of chromophobe RCC and renal oncocytic tumors by analyzing these tumors and explore potential oncogenic mechanisms in chromophobe RCC. We used single-cell RNA-seq data from chromophobe RCC, low-grade oncocytic tumors, and renal oncocytoma, as well as single-cell RNA-seq data from the normal adjacent kidney and these tumors. We trained a machine learning model on the normal cell types of the kidney. Subsequently, the model was tested on the tumor cells from each tumor type. In terms of the model features, we used an a priori defined list of 74 marker genes. These technically represent a comprehensive set of discriminatory features for each of the normal cell types of the kidney. So after training the model on the normal cell types and testing it on our tumor cells, we found a very high and selective predicted similarity between alpha-integrated cells of the kidney and each of the tumor types, from renal oncocytoma to low-grade oncocytic tumors and chromophobe RCC. We then thought to further validate our findings, and we did this through different approaches. The first one was by using an external chromophobe RCC single-cell RNA-seq dataset on which we tested our model. Again, we found the highest predicted similarity between alpha-integrated cells of the kidney and chromophobe RCC. Next, in order to improve our model and specifically the training set of the model, we decided to use a single-cell RNA-seq atlas of the normal kidney, enabling us to achieve a much higher sample size, talking about more than 16,000 cells, and enable a very specific annotation of the normal cell types in the kidney. We trained the model and we tested it on our tumor cells. We found an even higher predicted similarity between alpha-integrated cells and the 3 different tumor types. Then we thought to look at the expression of chromophobe-specific markers that were previously defined across the normal cell types of the kidney. And what we saw is a very high and selective expression of these markers in alpha-intercalated cells, as opposed to the remaining normal cell types of the kidney. Finally, we thought to look at some of the oncogenic mechanisms associated in chromophobe RCC. we should perform a differential gene expression between chromophobe RCC and alpha-integrated cells at the putative cell of origin. And what we saw was a marked downregulation of HLA class 1 genes in chromophobe RCC, along with the downregulation of HSP family A genes, which are known to be suppressors of ferroptosis. Next, we did a differential pathway analysis between chromophobe RCC and alpha-integrated cells at the single cell level. And what we saw was mainly a marked upregulation of ferroptosis-related pathways in chromophobe RCC and a major downregulation of antigen processing and protein processing pathways, which are essential for an adequate immune response. So in conclusion, our works helps to define the cell of origin of chromophobe RCC and suggests the path to think about some of the oncogenic mechanisms in this setting. I would like to thank everyone who contributed to this work, and most importantly, the patients and their families. Thank you very much.
Outstanding. I'd like to point out that Dr. Konda and Dr. Labaki actually had several seconds to spare within the 5 minutes allocated, which is very impressive. Next, Dr. Semaan is going to round out this trifecta of Dana-Farber colleagues to present data related to epigenetic profiling in sarcomatoid renal cell.
Hey everyone, thank you for giving me the opportunity to present my work at KCRS on epigenomic profiling of sarcomatoid RCC. So as you may know, sarcomatoid features in RCC are marked by the differentiation, or some may call it the differentiation, of epithelial cells into spindle-like cells. This pathological findings has been associated with worse outcome, and but luckily recent studies have shown marked response of sarcomatoid RCC to ICR. While distinctive patterns of gene expression have been identified recently in the literature in sarcomatoid RCC, gene regulatory elements and translational factors that drive sarcomatoid differentiation are still unknown. For that, our aim in this study is to nominate transcription factors responsible for sarcomatoid differentiation and then investigate their association with clinical outcome in patients with RCC. For that, we perform ChIP-seq on HEK27 acetylation, K4-dimethyl, and also MIDIP-seq for 10 sarcomatoid RCC tumor samples and 21 non-sarcomatoid RCC tumor samples. We then identified regulatory elements that were differently expressed between the two conditions using DSEQ2, and we used Homer to find enrichment of specific transition factor binding motifs at the upregulated site of sarcomatoid RCC. Finally, differential gene expression was done on RNA-seq cohort for on RNA-seq data from 3 different cohorts using DSEQ2. And finally, clinical outcomes were studied between sarcomatoid patients and non-sarcomatoid patients that were stratified by the quartiles of expression of each gene. So in these results, we can see that unsupervised clustering of HEK27 acetylation, K4-dimethyl, and MIDIP-seq respectively cleanly segregated the sarcomatoid RCC tumor samples from the non-sarcomatoid RCC tumor samples. Then, when we look at the upregulated sites in K27 acetylation peaks, they revealed enrichment for genes coding for inflammation, immune response, and also extracellular matrix organization, which is concordant with previous results in the literature, but on RNA-seq data. And this was consistent across multiple pathways, like the CAC pathway and the GO pathways. We then were interested to see if these sarcomatoid upregulated peaks were enriched for some motif enrichment for some specific transition factors. And Homer analysis showed that these peaks were enriched for FOSL1, which is a transition factor included and implicated in the EMT or epithelial to mesenchymal transition. We also found increased K27 acetylation peaks at the promoter of FOSL1 in sarcomatoid RCC tumor samples that was absent in the non-sarcomatoid RCC tumor samples. And also we found in the differential gene expression analysis that FOSL1 was consistently upregulated in 3 different cohorts, of course in sarcomatoid RCC as well. We then sought to evaluate the association of FOSL1 level of expression with the clinical outcomes, and here we're looking at the Chevron Renal 101 at the progression-free survival on the sunitinib arm only. And as we can see, non-sarcomatoid patients with high expression of FOSL1 and sarcomatoid patients had both worse outcome, while non-sarcomatoid patients with low expression of FOSL1 had better outcome. However, when we look at the ICI-based arm, we can see that both sarcomatoid RCC patients and non-sarcomatoid RCC patients with high expression of FOSL1 do now better and have similar outcome to non-sarcomatoid RCC patient with low expression of FOSL1. These results were similar and significant for response rate and overall survival, and we then validated these results in Emotion 151 cohort. In conclusion, and to summarize, in this study, we were able to further characterize the epigenomic landscape of sarcomatoid RCC by integrating CHIP, MEDIP, and RNA-seq data. Our findings implicated FOSL1 as a transcription factor or transcriptional regulator of sarcomatoid differentiation with potential prognostic and predictive relevance. Further studies are now underway to functionally validate these results and detect sarcomatoid RCC signal in cell-free DNA. I'd like to thank this wonderful team without whom this work wouldn't have been possible, especially thanks to Sylvain Baca, Matt Friedman, Tony Schweyer, and David Brown. And also thank you to my colleague Talal El-Zarif, with whom I was co-leading this project. Thank you everyone for your attention.
Thank you, Carl. We now have a 6-minute break for questions and answers.
The speakers, so I think please, you can shut me anytime. So I think Prathyusha, that question, I mean, I think really nice presentation. And my question was, have the metastatic samples been clubbed with the primary tumor for this analysis? Because I feel that the metastatic tumor transcriptomic profile gets heavily influenced by the metastatic environment. So I think at least might be good to look at the data parsed out separately between the primary tumors. And I mean, and your group might have done it already.
Yeah. So you're talking about the sarcomatoid sample?
No, actually the MIT of RCC in terms of single cell sequencing.
Yeah, so the tumor-intrinsic analysis that I showed actually does not include the metastatic sites. It's only the primary samples that I analyzed. Metastatic analysis is separately performed.
So in terms of the single cell sequencing, we have also done, I mean, actually the TFE3 translocated RCC, we have predominantly seen emanating from the proximal nephron, but the TFE-B renal cell carcinoma, some of them we have seen from the distal nephron. Thanks. And for Chris, so the lot or the low-grade oncocytic tumor which was mentioned, is this the TSC-mTOR mutated low-grade oncocytic tumor? Because I think there were 3 tumors which were profiled: chromophobe renal cell carcinoma, renal oncocytoma, and a tumor called LOT, low-grade oncocytic tumor. Is that the one you're referring to?
So technically, we're referring to the new specification regarding the classification of genitourinary tumors of the kidney. So this is not based on mutation calling. This is based on purely histopathological assessment following the latest guidelines in the setting and not based on mutation data.
Actually, that's the reason I'm asking, because the low-grade oncocytic tumors are associated with the mTOR TSC mutation. So I think that might be good to confirm. And my last question was for Karl. So I think data from MSK has shown that about 5 or 6% of sarcomatoid renal cell carcinoma have JAK2, PD-L1, PD-L2 amplifications. So I think this analysis could be done in terms of also dividing the data set between the cases which have those amplification and the tumors which don't. So it might be interesting to check. Thank you.
Okay. Thank you.
Yes, Dr. Shuri.
I mean, this is important. When I introduced Rohit, who's a superstar pathologist from Michigan, we're open. I mean, we're focusing as Dana-Farber Harvard Cancer Center and BI to a lot of these unmet need, but it's very, very hard really to do them. I mean, your centers with your urologists, Medonc, see a lot. We'll be happy, you know, to work with you and many folks in the community to have samples from these rare tumors.
Dr. Henske, I think, had a question.
Yes, I was going to ask also about the interesting cell of origin for the translocations. Do you think that the different translocation partners may be nephron segment specific in some way?
So I checked the expression of the partner genes within proximal tubule versus connecting duct tubule from the normal cells. And I don't see any differential expression in that from the data that I looked at. But this is also just from one cohort. I need to expand the analysis to more cohorts and see if there is anything there. But so far, it doesn't seem to be connected.
Sorry, Tony.
I want to hurt.
You almost got me. So I think amongst the MITF-RCC, since now we have these three distinct categories of TFP translocation, TFP translocation, TFP amplification, it might be good to see these three different categories have different tumor origin. We do know that the TFB translocated RCC do have 60 or 70% of them have c-KIT expression, which is an intercalated cell marker. So I suspect at least a subset of those are coming from distal nephron.
Wow, that's really cool. Thank you for sharing.
Okay, I have one question for Chris and one for Carl. So Chris, my question to you is, do you foresee your research to be applicable in terms of diagnosis? You know, like sometimes we have in a biopsy something that we are not sure it's a chromophobe or, you know, oncocytic low malignancy potential tumor. Do you foresee that to be applicable?
Yes. So yes, the short answer is yes, for a few simple reasons. We're currently using single cell RNA-seq data. We're not going to do this on niche biopsy. However, we're using a limited set of marker genes, which are discriminative features for the normal cell types of the kidney. So technically, I would foresee this to be applicable in other settings. If we're able to define a very specific framework, it could be possible.
Thanks. And Carl, just to make sure we understood fully, your way of thinking is that through methylation of FOSL1 promoter, that would actually impact all your transcriptional pattern afterwards, getting to sarcomatoid dedifferentiation. Or
Yes,
is, I want to make sure.
Yeah, sorry. I would say acetylation, not just not methylation. And it could play a role down in the downstream expression of other genes and explain why there is so much epigenetic differences between CCRCC with no sarcomatoid differentiation and CCRCCs that then evolve to sarcomatoid differentiation.
And so what's, you mentioned in your conclusion slide, the functional analysis that you're ongoing. Could you share your experimental design?
Yeah, so we're looking forward to trying to overexpress FOSL1, for example, in a CCRCC cells with no sarcomatoid differentiation. And we hope, our hypothesis is that we would see epigenetic differences after we overexpress FOSL1 that start resembling sarcomatoid epigenomic profile that we are seeing right now.
Thank you all. We're going to move on to the next two abstracts. I'd like to invite Dr. Schoenfeld to discuss a modified IL-18 drug in combination with CTLA-4 blockade enhances anti-tumor efficacy in preclinical models of RCC.
Okay, I'd like to thank the organizers for the invitation to speak. So to get started, IL-18 is generally thought to be a pro-inflammatory cytokine capable of stimulating innate lymphocytes and antigen-experienced T cells, among other functions. For this reason, IL-18 has been tested previously in clinical trials. And while it was well tolerated, it lacked efficacy. However, it was known that IL-18 stimulates the secretion of a high affinity binding protein called IL-18BP, as shown schematically here. And in this study that came out a couple of years ago from Aaron Ring's group, they showed that this secreted binding protein can function as a secreted checkpoint and block IL-18 activity. And then they generated a decoy-resistant version of IL-18, which they termed DR18, that was still capable of stimulating the immune receptor, but was resistant to binding by this secreted immune checkpoint. And then they validated this in some preclinical models and showed that it had activity. So we thought this would be an interesting compound to test in RCC, not only because of the demonstrated immune responsiveness of RCC, but also because they showed in the study that RCC was among the cancer types that had elevated IL-18BP transcript expression compared to normal tissue. We also quantified IL-18BP expression in the RCC stroma and showed that in pre and post IO samples and showed that In IO responders, IL-18 BP levels didn't change, but in IO non-responders, there was a significant increase in IL-18 BP levels. So we plan to test DR18 in combination with ICIs, both single and dual agent checkpoints, including anti-PD-1 and anti-CTLA-4 in two immune competence and genetic models, the RANK and RAG models. So here we see the survival curves for the RANKL model. We see the unmodified IL-18 crimson showing no effect. We see the DR18 compound having modest anti-tumor activity in the red line, roughly equivalent to single and dual agent immune checkpoints. Interestingly, we combined it with anti-PD-1. There was no additive benefit. However, when we combined it with anti-CTLA-4, there was significant anti-tumor effects and a prolonged survival. And also notably, it was equivalent to triple therapy. We saw similar results in the RAG model that we tested. And we also looked in the melanoma model and saw that DR18 in combination with anti-PD-1 or anti-CTLA-4 was equally efficacious. So we thought this would be an interesting combination to test further and look for the cellular mechanism of action. We plan to look at cytokine and chemokine profiling and also conduct single cell RNA-seq analysis. We also performed immune cell depletion experiments in the RANKL model, and here are the results. We saw that CD8 cells, NK cells, and interferon gamma were required for efficacy, whereas CD4 cells seemed less important. Here we see the results for the cytokine and chemokine profiling at 2 time points after treatment 1 and treatment 3. I think the broad take home from this is after the 3rd treatment, we see a broad increase in inflammatory cytokines with the combination regimen. If we focus in, however, on the early time points, so 24 hours after the first treatment, we see interferon gamma being significantly increased as expected, but we also see IP10, also known as CXCL10, and MIG, also known as CXCL9, going up rapidly and significantly. These are induced by interferon gamma, known to stimulate the recruitment of Th1 cells, NK cells, macrophages, and dendritic cells, potentially implicating them as key early mediators. And to quickly talk about some of our single-cell RNA-seq findings, so here's a UMAP plot of all cells across all conditions, identifying the major immune cell types. When we quantify the relative proportions of these immune cell types across the different treatment conditions, we see an enrichment of granulocytes with DR18 containing regimens shown in the bottom blue bars. In the combination regimen, we also see enrichment of CD4 and CD8 cells. And then in the interest of time, just focusing in on the T cell subset where we did further analysis. So we conducted unsupervised quantitative analysis using differential abundance analysis and nearest neighbor clustering. And when we did this, and we focused on clusters that were enriched with the combination regimen versus those de-enriched with the combination regimen, and then focused on distinguishing features between these two neighborhoods, we see numerous actors of CD8 cytolytic activity, activation, and also some markers of exhaustion. We also confirmed these results with semi-supervised analysis using annotated data sets and saw enrichment of precursor exhausted and terminally exhausted CD8 cells, and TCR analysis identified clonal expansion with the combination regimen. So just to quickly conclude, we see activity with DR18 and anti-CTLA-4 in preclinical RCC models, more than with anti-PD-1 combination. CD8 T cells, NK cells, and interferon gamma are required. We see induction of interferon gamma, CXCL10, CXCL9, and then we see an enrichment and clonal expansion of effector CD8 T cells. And then where are we going with this? We plan to test this regimen in other models, including ICI-resistant models lacking beta-2 microglobulin, or also some re-derived lines that we created. We also plan to test this in the LVRCC67 line. We also plan to test DR18 with other interesting drug combinations. We also plan to move forward with a phase 1 trial in resistant RCC and melanoma based on these results. So I want to thank my mentor, Harriet Kluger from Yale, our collaborating labs, and also some sources of support. Thank you.
Once again, well within the allotted time, which is outstanding. So, bringing everything full circle, we've had lots of discussions around ferroptosis at this meeting. It's a real delight to welcome May Ko, who I met initially several years ago at the University of Utah, who's going to be discussing a therapeutic targeting approach for this.
Well, thanks for that invitation. So my name is May Ko. I'm founder of CUDA Therapeutics, a little startup, and my day job as assistant professor at the University of Utah. And so like many of us here in the room, one of my research focuses is on identifying and exploiting the key vulnerabilities of ccRCC. And we all know that VHL loss drives HIF, and we know HIF is now a validated target for RCC. And we know the VHL loss also drives the lipid accumulation that, from the talks today, sensitizes these cells to lipid peroxidation or ferroptosis. We've heard other talks today about SETD2, PBRM, and BAP1 loss that also confers sensitivity to DNA damaging agents, potentially through ROS. And so I'm going to talk about a novel agent we discovered that impacts, we think, at least all three of these pathways I'm talking about. And lipid peroxidation and ROS are, of course, hallmarks of ferroptosis. Many people have talked about ferroptosis kind of incidentally today. And so I just want to give a little bit of background in my little short time here. So ferroptosis is a novel form of cell death that is distinct from apoptosis. So it's more necrosis-like, and more importantly, cells that are resistant to apoptosis retain sensitivity to ferroptosis, or they might even become more sensitive to ferroptosis. So that's an important key distinguishing factor. We heard about PUFAs, polyunsaturated fatty acids are the rate-limiting substrates for ferroptosis. So these unsaturated fatty acids can be oxidized, and CCRCC, because of their high amounts of PUFAs, are sensitive to ferroptosis. And we also heard other results from chromophobe and other kidney cancer cell types that could be sensitive to ferroptosis as well. The little cartoon I show here really are the pathways, the main pathways regulating ferroptosis. So you see uptake of cysteine by XCT transporter, which then gets converted to glutathione and then made into GPX4 that protects against ferroptosis. And then we have the PUFAs that increase sensitivity to ferroptosis, as well as increased iron uptake that also catalyzes the oxidation of lipids. So we have antioxidants, and then we have the PUFAs, and then we have iron. So erastin is one of the known blockers of XCT, and RSL3 blocks GPX4. These are known ferroptosis inducers, but they don't work really well in vivo because of their PK properties, because of redundancy. So we don't really have any good ferroptosis inducers in vivo. So long story short, about 10 years ago, I was looking for small molecule inhibitors of HIF2 alpha. And what we found was something called an iron sulfur cluster assembly 2 inhibitor, which I had no idea what it was. This helps make iron sulfur clusters in the cells. But suffice to say, in the interest of time, when you block that, you decrease HIF2 alpha translation. You also block HIF1 alpha translation. You decrease ISCA2. You make the cells think they have no iron because they can't make these clusters, so they take up a lot of iron. And then from this Bodipi plot, you see we actually increase lipid peroxidation, presumably because they have more iron. And then a cell viability assay plot here. So in the black line, you see treatment with one of our earlier compounds, 025, causing cell death. The dotted line, treatment with ZVAT, apoptosis inhibitor does nothing. Co-treatment with lipoxystatin, a ferroptosis inhibitor that protects against 025. Of course, in vivo, proof is in the pudding. So we have Ranker model here, which we know has its flaws, but at least for proof of concept, we show that oral treatment with 061, a newer version of our inhibitors, black curve vehicle, and then PD1, some anti-tumor activity. These tumors were treated at rather high when the tumors were rather large, and then at higher concentrations of significant anti-tumor activity. And most importantly for us, we have evidence of target engagement. So we have decreased HIF1 alpha and HIF2 alpha protein, decreased angiogenesis. And the first time this has been shown, increased lipid peroxidation within the tumors through oral administration. So we're pretty excited because we've shown proof of concept. ISCA2 blockade decreases HIF, induces ferroptosis orally. These mice seem fine. We might discover things later, but this seems well tolerated. And so we serendipitously stumbled upon a new way to induce ferroptosis independent of RSL3 or erastinol, those pathways. So mechanism of action, because it's kind of fast, I know. So we block ISCA2. ISCA2 is involved in the iron sulfur cluster assembly. So when you block that, the cells can't make clusters, and they think they have not enough iron. And so they take up more iron that promotes ferroptosis and cell death. And also because they can't make clusters, we never talked about IRP1, but IRP1 needs a cluster. And if it loses its cluster in this cartoon here, it binds the HIF2 alpha IRE, blocking HIF2 translation. Now we don't quite know how HIF1 goes down, but it does. But anyway, we see a dual effect now of inducing ferroptosis and blocking HIF1 alpha as well as HIF2 alpha. So with that, I'd like to end and really acknowledge the SBIR and the kidney cancer program, as well as we now receive a phase 2 grant. It's really helped us build a company for someone in academia, just trying to manage 2 things, and nobody will give me money because I'm in a university. So this is how we got this far. So thank you.
That was terrific. And I bet if we knew how often ferroptosis would come up during our dialogues during this meeting, we would have allocated at least a couple more minutes for your talk there. So well done. Questions from the audience?
Could there be, I mean, great work, been following your work since you first presented at this conference. Could it be by a different mechanism than HIF, like something that you haven't seen? And could this be, used in way? Have you looked at chromophobe renal cell with all the ferroptosis talk with Lisa Hensky and others?
So the first question is, I think you were asking whether the ferroptosis is HIF dependent.
Yeah, in the
And-
first. And how much is it HIF dependent?
So,
Could be
so
dependent.
it's completely HIF independent because we're blocking ISCA2, which is upstream. So ISCA2 has one effect like that little pathway I showed. It promotes iron accumulation, and that's what we think promotes ferroptosis. And because HIF is iron regulated, HIF translation, so that's why HIF is affected. Now, HIF can indirectly promote accumulation of PUFAs that increases sensitivity. So HIF might reprogram the CCRCC already, so that is one effect, but the effect of the drug is actually HIF independent. And with regards to chromophobe, we're working on it. That's the short answer for that.
Next year.
Dr. Beckerman.
Hi, wonderful talks. This question is for Dr. Schoenfeld. I had two questions. I wondered if you might comment on your hypothesis, why you see the synergism in your preclinical model with CTLA-4, but not with PD-1, and I may have missed that. And then also your rationale for testing the combination in a refractory setting rather than a untreated patient population.
Right. So we don't know actually why it works better with CTLA-4 versus anti-PD-1 right now. I think that's a key question. Some theories, we do see induction with the DR18 of CTLA-4 levels more than we do anti-PD-1. They both do go up. It could have something to do with Tregs. We do see changes with Tregs more with just the DR18 and CTLA-4. Well, we'll probably deplete them maybe more in mice than humans, so it might be something that doesn't translate as well. But I think that's something that we're actively exploring, both probably in the mouse and maybe some in vivo human studies or in vitro human studies. And then the second question, the resistance setting versus upfront, just I think it might, our thought was that it might be easier to do that study. And we don't have it, or we're working on it, but the initial paper that I highlighted showed that it has activity with loss of beta-2 microdevelopment and some other common mechanisms of ICI resistance. So, suggesting that there might be activity there in humans.
Dr. Hensky.
Yes, I have a question for May. There is evidence that ferroptosis induction can alter the tumor immune microenvironment, and that ferroptosis-inducing agents can be combined with immuno-oncology agents. Have you looked at that at all in your RENCA model?
So we have, and we only did it kind of superficially because we combined the study you saw, we just combined the two doses, and the mice, it wasn't tolerated, but we haven't titrated dose. We haven't done anything like that, but there is, yes, I'm familiar that, the CD8 T cells secrete interferon that takes down XCT and does the whole thing with the cysteine. So there is potential for combination there. We just need to find the dose.
Excellent. Well, I think we're right on time here. So, we'll roll right into our last three presentations, and we're going to veer more towards the clinical now. It's really a pleasure for me to introduce Daniela Castro. Daniela is a really talented student who came to us from UCSD undergrad and is working as a clinical research associate within our group. And this is actually her second international kidney cancer presentation. So we're looking forward to hearing her discuss the impact of insurance status on outcomes in patients with metastatic renal cell carcinoma.
Thanks for the introduction, Dr. Pal. Good afternoon, everyone. Thank you for the opportunity to speak with you today. I will be discussing our study, which assessed the impact of insurance status on clinical outcomes in patients with MRCC. So in addition to the previously studied socioeconomic factors that affect health disparities, recent literature has shown that insurance status can serve as a prognostic factor associated with overall survival in patients with RCC. Additionally, Some studies have shown that access to health insurance has resulted in earlier detection of disease. As a result, we had an interest in exploring the impact of primary and secondary insurance status on the clinical outcomes of patients receiving first-line systemic therapy for MRCC. So patients with MRCC from City of Hope and Huntsman Cancer Institute with available insurance information diagnosed between 1990 and 2022 were retrospectively identified using institutional databases. From here, primary insurance information was collected and categorized into 3 groups: those with Medicare, private insurance, and Medicaid or no insurance, while secondary insurance status was defined by the presence or absence of secondary coverage. From here, PFS and OS were estimated using the Kaplan-Meier method and compared based on insurance status by log rank tests. Multivariable analyses were performed to examine the impact of insurance status on clinical outcomes. So in terms of our summarized study demographics, in the overall cohort, the age at diagnosis ranged from 22 to 94 years, with the median having been 60 years. And most patients included in our study were male and white. However, several other races were represented. And in fact, over 16% of our population were Hispanic or Latinx patients. And the majority of patients had primary insurance alone, as well as clear cell histology, and received targeted therapy for their first line of treatment. When comparing different types of primary insurance, we see a broad distribution in PFS. Specifically, we saw that patients with Medicare had a median PFS of 7.7 months compared to 5.5 months and 4.9 months for patients with private versus Medicare or no insurance. And by log rank tests, a significant difference in PFS across the 3 types of primary insurance was observed. Using Medicare as a comparator, we also saw significant differences when comparing to the other 2 types of primary insurance, which can be seen in the p-values listed in the table. Then comparing PFS by secondary insurance status, we also saw some variability between patients with secondary versus without secondary insurance status in terms of median PFS. And by log rank tests and multivariable analyses, we also observed statistically significant differences in PFS, which further supported the association between secondary insurance status and PFS in this setting. In terms of OS, we found that the median OS also varied by insurance type and by overall log rank tests and multivariable analysis for with adjustment for possible confounders. We also found that there were established differences between patients with Medicare compared to Medicaid and uninsured groups, as well as Medicare versus private insurance. Lastly, we assessed OS by secondary insurance status, and here we did observe some marginal differences in median OS in the 2 groups. However, these results did not yield statistically significant differences in terms of log rank tests and multivariable analysis with adjustments for other factors. So in conclusion, we found that patients with primary Medicaid and no insurance, as well as private insurance, had inferior median PFS compared to those with primary Medicare. Also, patients with secondary insurance had superior PFS over those with primary insurance alone. So overall, our findings suggest that insurance status may serve as a determinant of clinical outcomes. And as a result, these data are warrant external validation in prospective studies. Thank you to everyone for your attention and to our research team, the patients, their families, everyone involved, and our collaborators at Huntsman. Thank you.
Thank you, Daniela. Next, I'd like to invite Chinmay Jani from University of Miami Sylvester Cancer Center to discuss examining trends in kidney cancer mortality by gender and race in the United States at 20-year analysis.
Good afternoon, everyone. I'm Chinmay. I'm former chief resident at Mount Auburn Hospital and Harvard Medical School, and just started my fellowship at University of Miami. So thanks KCRS for allowing me to come to Boston again, to home, in my first week of fellowship. So kidney cancer, as we are here and we are at KCRS in past 2 days, we know it has a significant impact on world cancer mortality. And there are lots of different disparities which we are trying to investigate. Therefore, it's the right time with an increasing incidence of kidney cancer all over the world to identify these different disparities and risk factors so that we can have appropriate healthcare policies addressing these disparities. With that, in our aim, our aim is to investigate trends in age-adjusted mortality rate by gender, race, and ethnicity in the US at national level. We use CDC Wonder database using ICD-10 coding C64 from 1999 till 2020. It was done based on per 100,000 population. Absolute percentage changes were calculated, and then to evaluate the trends, how it happened over in past 20 years, we did joint point regression analysis using the NCI software of joint point command line version. So going directly into the results, over 20 years, we have seen almost 284,000 of kidney cancer deaths that have been reported in United States. If you see overall, we have done really great. There has been decrease in mortality for all different subgroups, whether it's gender, race, or ethnicity. However, interesting findings you will see over here, male has done significantly worse throughout the study period. In race, American Indian population and Alaskan Natives, they started really bad at 5.7, which is with a maximum and significant improvement overall. And right now, white population is having the worst outcomes as compared to other racial groups. Similar is with ethnicities as well, that non-Hispanic whites are having far way worse outcomes as compared to others. Going into subgroups, overall, we can see similar findings here as well, that American Indians in both males and females have done significantly better, with only minor changes in white population, especially for males. And we'll go into the joint point trends as it will give us more impact on how these trends have been. So you can see for the first graph for male and female, in the female, there was a decrease in mortality initially and then a constant steep decrease. However, look at the disparity that there's a significant gap overall. And more concerning finding is somewhere over here in 2016 to 2017, that the mortality is now again going up for males for kidney cancer. For race, American Indians, the reporting is not that great and robust, but still significant decrease. And now with white population having a little bit higher, with these three racial groups getting clustered, and Asian population having significantly better throughout the study period. Similar things we have seen in our joint point trend analysis for females and males as well. Again, for females, American Indians and Alaskan Natives still have higher mortality as compared to all four subgroups, with Asian females having almost similar mortality throughout the study period. And for males, we can see that American Indians have shown significantly decrease, whereas white population initially showed an increase and then decrease as well. And Asian males have constantly remained at a lower end. So summarizing our overall results, our study highlights that even though we have done significantly better in kidney cancer mortality, there's still significant gender, racial, and ethnic disparities in kidney cancer. While overall mortality has decreased in recent years, there's still disparities that we need to address, especially with males. As you saw, there was a very wide gap between the male mortality as well as the female mortality. Looking at the racial groups, American Indians, we need to focus on their reporting as well as targeted efforts on how to improve their mortality, even though they have done already great. But now next step is to have a focused efforts on white population as well, as white population is now having higher mortality as compared to other racial groups. And with this, even for Asian females, the groups which did overall better or which did just the same was particularly Asian females and Asian males. if we have done so much of improvement and mortality has decreased for other groups, we would expect that it would be decreasing for those groups as well. So there needs to be focus on that population as well. And so with that, our conclusion remark is that with these results, we would like to inform the healthcare policies as well as practices that aim to address these disparities in kidney cancer mortality rates and ultimately improve the healthcare outcomes for all the population. For acknowledgements to all my co-authors and MDR collaborative group, on my first slide, I had Dr. Anna McKay, who's my project guide as well for this. So thanks a lot. And that's our beautiful campus at University of Miami. So please come and visit us. Thank you.
And in closing out the session is a really exceptionally talented fellow from the University of Utah, George Gebrael, who works with my dear friend and colleague, Dr. Neeraj Agarwal, and he'll be discussing synchronous versus metachronous MRCC and impact on outcomes with checkpoint inhibitors.
Thank you, Dr. Pal, for this introduction. Good afternoon, everyone. Thanks for surviving until this last presentation. I'm very delighted to stand before you today at the KCRS to share with you the findings of our study entitled The Impact of Time to Metastasis, means synchronous versus metachronous MRCC, on outcomes in patients treated with first-line immune checkpoint inhibitors-based combination. According to the latest data provided by SEER, around 15% of patients present with distant metastasis at the initial RCC diagnosis, known as synchronous MRCC. However, around 82% present with localized or regional disease, and subsequently they might progress to metastatic renal cell carcinoma, and then it will be known as metachronous MRCC. It was previously shown that patients with synchronous MRCC have poorer outcomes compared to metachronous MRCC patients when they were treated with the previous standard of care, VEGF TKI monotherapy. Therefore, the aim of the study is to investigate whether synchronous versus metachronous impact survival outcomes in patients treated with the current standard of care immune checkpoint inhibitor-based combination. So we conducted a study after including patients with confirmed diagnosis of MRCC who received first-line immune checkpoint inhibitors-based combination, which means at least one anti-PD-1, anti-PD-L1, or CTLA-4 inhibitors. We excluded patients with data missingness regarding date of diagnosis or date of metastasis diagnosis. And then we categorized patients into two groups: synchronous, it means patients who had metastasis diagnosis at the initial or within 3 months of RCC diagnosis, or metachronous MRCC, which means the occurrence of metastasis lesions 3 months after, after more than 3 months of the initial RCC diagnosis. And we looked at time to treatment failure, overall survival, and disease control rate per RECIST 1.1 criteria, which include complete response, partial response, and stable disease. So overall, we included 223 patients, with 97 patients in the metachronous group and 126 patients in the synchronous group. In terms of baseline characteristics, they had similar age, sex, histology, and brain, bone, liver mets. If we look at the individual IMDC risk criteria, patients with synchronous MRCC had more anemia, more thrombocytosis, and more neutrophilia. And they had more IMDC intermediate poor risk. Let me start by time to treatment failure. So TTF was 9 months in the synchronous group compared to 19.8 months in the metachronous group. Although we have 10-month difference, it wasn't statistically significant. Moving to overall survival, it was 28 months compared to 50.9 months in the synchronous compared to metachronous group, with a hazard ratio of 2.23. After adjusting for potential confounders such as age, sex, histology, and IMDC risk, synchronous versus metachronous status remained an independent factor associated with shorter overall survival. In terms of disease control rate, synchronous has a 62% of disease control compared to 86% in the metachronous group. Also, after adjusting for potential confounders, synchronous versus metachronous remained an independent factor associated with lower disease control rate with an adjusted OR of 0.29. So the limitations of the study are the small sample size and the retrospective nature of the study. In conclusion, patients with synchronous disease appear to have shorter overall survival and lower disease control rate compared to patients with metachronous MRCC. For sure, further validation is needed in larger prospective cohorts, And these data, after validation, could inform future clinical trials design. And finally, I want to thank Dr. Pal and Dr. Agarwal for their guidance and support, and for sure the wonderful team from the City of Hope and the Huntsman Cancer Institute that made this project or study possible. Thank you so much for your attention.
We have 6 minutes for questions and answers before we wrap up the session.
Wow.
Evan?
Oh, yeah.
Evan, Evan.
Sorry.
No.
Great presentations. Really exciting to see something a little different and more population-based at the end. Questions for Dr. Castro. What do you think is going on? Obviously there's the direct financial costs of the drugs and the care, the indirect costs of disrupted work and other things that could interact with the patient's socioeconomic status. But do you have any sense of which of those things is most impactful, or how you might do further analysis to clarify that?
So thank you for your question. I think in terms of when we break down the different patient demographics within our study population, we did see the most variability across different types of insurance when it comes to ethnicity and secondary insurance status. So the vast majority of the Hispanic and Latinx subpopulation of patients had Medicare or were uninsured. And we saw a minority in the group with Medicare and as well as private insurance. And then in terms of secondary insurance status, the vast majority of patients that did have secondary insurance were in the Medicare group. So I think some of it might be demographically driven. And to answer the other part of your question, I guess moving forward, one thing that we could look at is including insurance type and status as an aspect of clinical trial design, and just start building registries and collecting this data prospectively and longitudinally as we conduct trials to then so that we can then assess how they are related to the outcomes at the end.
Tony?
I'm just intrigued a lot by ferroptosis again, Dr. Ko. Just overall, and I'm not an expert in ferroptosis, but one question is like, what would be, I would say, like, do you need to induce it? Do you need to suppress it? Is there any cellular states where perhaps, you don't need to induce it, you need to suppress it? Like, I think the balance, we still don't understand a lot, and the balance may be more complex than we think.
So that's a great question. It's a question for the ages. So to answer in a short amount of time, from the earlier talks in the earlier session, we saw that there was more cysteine in a lot of these tumors. And so we know that that's because tumors have to cope with higher levels of ROS. They're just stressed and they're on the brink. And so therefore for tumor cells, CCRCC, but a lot of tumor cells are stressed, and so they would be sensitive to ferroptosis. So in those cases, you want to induce it. But in terms of like fatty liver disease, neurodegeneration, a lot of those have been shown to be linked to ferroptosis as well. So people want to suppress ferroptosis if you got fatty liver disease, if you have Alzheimer's or any Parkinson's. So it's a developmental procedure to get rid of unhealthy cells, but it goes awry, as we know, disease and old age, but we can harness it, at least in cancer. And it's been suggested that immune cells kill tumor cells by ferroptosis through the interferon gamma link. So it's an exciting prospect. I know I'm biased, but I think it's a very exciting prospect for cancer.
Dr. Salgia, Jr.
Oh, sorry.
Dr. Castro, you did a great job, a very thought-provoking talk. I think that has a lot of clinical implications down the road and even today. So your database really went back all the way to the early 1990s or the late 1990s, if I remember correctly. And in that time period, we've had a lot of changes go on, not just in the way insurance is provided in this country, think about 2008, the Affordable Care Act, but also in the cost of drug prices in that 25-year span or so. Were you able to look at, if these trends hold true in the biologics age, where these anti-PD-1 inhibitors are tens of thousands of dollars a year per patient compared to maybe cheaper regimens, but then also the changes from pre-2008 or so to post-2008 based on the way insurance status has really changed based off that cutoff?
Thank you for your question. So we haven't actually looked at the changes across the timeline that we did look at, but I think that would be a really interesting potential trend that we could look at down the line. We're currently working on the manuscript, so maybe that's something we could look at into adding for the discussion. But you do bring up a great point about how insurance did change after 2008 compared to before. And I forgot the second part of your
just changes as the cost of therapies have evolved, again, in more of a longitudinal look
So-
into it. Yeah.
Okay, in terms of the cost, that's also not something we've looked at yet, but I think that could be interesting to pursue and see if that does play a role, because I'm sure it does in the trends that we did observe.
Thank you. Really fantastic work.
Thanks.
All right, and I think we'll close things out right on time here. I'm going to thank all of our presenters today, including my co-host for this session, Deepak, and I think Brian Luce is going to close us out.